Okay, so on this video, I'm going to wrap it up with diabetes. I'm going to start off now with metabolic syndrome, okay? And metabolic syndrome is basically a combination of obesity, high blood pressure, uncontrolled hyperglycemia, okay? Diabetes, and hyperlipidemia or high cholesterol, high triglycerides. The combination of any of those four is considered metabolic syndrome because technically you're having issues in your entire system that are going to cause some type of disease sooner or later. An individual with metabolic syndrome is at higher risk for cardiac disease, fatty liver, renal failure, and as you can imagine, that every disease under the sun of diabetes. I left off on metformin in the last video, and it said that I didn't want to mention too many names on pharmacology, but metformin is one of the key drugs. As a matter of fact, it's the number one used drug in managing a diabetic type 2 patient. In diabetes type 1, we already spoke that you need insulin no matter what. So forget about oral hypoglycemics, all right? Diabetes type 1, you're monitoring it with insulin, and you go to the sliding scale and you monitor your patient's glucose. And depending on how their glucose and their little journal goes, and their hemoglobin A1C, you adjust their insulin. In diabetes type 2, it's easier to manage because you do have oral medications, you know. Metformin is a great drug because it actually has some weight loss benefits. Okay, one of metformin's functions, is to stop a process of gluconeogenesis. Okay, and I'm not going to get into how gluconeogenesis occurs, but gluconeogenesis is the formation of glucose. Okay, from lactic acid and from any other means of producing glucose, and there are several which we could talk about in a nutritional video later on. So gluconeogenesis is how we get stored glucose, and how we get a glucose that isn't stored, that comes from fatty acids or from lactic acid that's left over from anaerobic respiration or anaerobic metabolism. The liver recycles this anaerobic metabolism leftovers and puts together glucose and releases it whenever the body needs it. Okay, this drug, one of its functions is by blocking the liver's ability of gluconeogenesis. Okay, so it will reduce the hemoglobin A1C just because of the fact that it has this ability to somewhat control the release of glucose. Now, what's another thing? You could still have you could still block gluconeogenesis in the liver pretty well, but if you're still eating little chocolate bars here 3-4 times a day, drinking your soda, eating sugar-rich foods, carbohydrate-rich foods, and you're not really taking care of yourself with physical activity and diet, guess what? Your glucose will still spike up. Okay, so metformin is not a miracle drug that you could just take and think you could eat whatever you want. Another mechanism of action for metformin is that it doesn't upregulate insulin receptors, but it makes insulin receptors more sensitive to insulin. Okay, the mechanism of action is it's pretty cool actually if you look at it, but the receptors become more sensitive to insulin, and it's somewhat like if you're regressing your diabetes type 2, because in a diabetic type 2, we know that insulin is provided to us by the pancreas, but our receptors are becoming ignorant to the insulin. So metformin actually helps these receptors become more sensitive to insulin again. So you have more uptake into your cells of glucose. It's another mechanism in which it works. And last but not least, it's inhibition effects of glucose absorption. I think it's through the GLUT4 in the GI, gastrointestinal system. I'd have to double check. But it does block glucose absorption in the GI as well. Okay, doesn't mean that it stops it, but it does minimize the amount of glucose that jumps into your portal circulation right away as you eat. So it has three mechanisms in which this drug works. Okay, it has some side effects like every drug does, but they're minimal. I mean, some GI effects, and of course, like any other oral hypoglycemic, you have a risk of hypoglycemia if you're not eating right. Okay, you gotta make sure you eat too. Just don't eat a chocolate bar like this guy's doing right here. Eat, So you definitely want to watch out with your diet if you're in metabolic syndrome, because it's not just diabetes alone and hyperglycemia alone, but you have a combination of all of these things: high cholesterol, glucose, high blood pressure, and obesity. And one thing that I want to point out is that a key thing in body shape, so an apple shape versus a pear shape. This guy here is more of an apple shape. If you look at his legs, they're not really that fat and I apologize for the word fat, but they're not really that obese or overweight compared to his midsection. Okay, a thing about metabolic syndrome is that your midsection, okay, when you have more fat in your midsection, this fat is easier accessed, okay, by the portal circulation and by your liver. So you have a higher risk of getting fatty liver and heart disease when you have midsection obesity, as opposed to just a pear-shaped body where you have equally distributed obesity. If anyone knows how this is, I mean, please let me know the physiology behind it. But from what I understand, just being apple-shaped and having more fatty tissue distributed through your midsection as opposed to throughout your body makes fatty tissue more available, easily available to your liver, and it overwhelms your liver and your circulatory system more than a generalized distribution of obesity, of fat cells. So in conclusion, for diabetes, we understand the effects that it has now on the vasculature. We understand diabetes 1, diabetes 2, how you could treat it, how you could manage it through diet. I want to talk a little bit on differentiating diabetes type 1 and type 2, just in case somebody was wondering. And a diabetic 1 patient, typically it happens in childhood, but it could happen later in life. If you've had diabetes 2 for a long time, it's been very uncontrolled. Or you don't have to have diabetes. You could just maybe get a severe infection, autoimmune disease, and all of a sudden become a diabetic type 1. But in either case, patients that suffer from diabetes 1 for the first time tend to have a lot of, they go into diabetic coma, or they have very severe symptoms to where they need to be hospitalized. And once you do the studies of glucose and you know that they're diabetic, because of how severe they were, you could pretty much guess that they were diabetic type 1 or differentiate diabetes 1 from diabetes 2. But officially, there's an autoantibody test that you could do. And if this autoantibody test comes back positive, then you obviously know that you have antibodies, which may lead to diabetes type 1. Okay, it's I don't know the percentage rate, but if you have autoantibodies positive and you suffer from diabetes, you don't always have diabetes type 1. You could be a diabetic type 2, but for the most part, positive autoantibodies with a confirmed diabetes means that you're a diabetic type 1. Okay, once again, the history, the signs and the symptoms are going to be the #1 indicator for most of your diseases. Okay, there are a lot less diseases that are only diagnosed through labs. A lot more of the diseases out there you could diagnose just through a good history and symptoms. Okay, that's why it's important to understand your physiology. I think that's enough now for differentiating for diabetes 1 and diabetes 2. Something that I want to talk about is diet. I kept on mentioning diet and lifestyle modifications. To keep it simple and not go into too much detail, what you want a diabetic patient to eat, what everyone should be eating, is you want to make sure that the carbohydrates of foods that they eat, whenever they do eat carbs, make sure that it's as natural as I mean. What I mean by natural is brown rice instead of white rice. Okay, brown rice has all the minerals, and it's harder to get through that brown layer and get the carbohydrate and break it down into glucose through brown rice than it is through white rice. And white rice, you don't have those layers, so the stomach and the GI system breaks those carbs down very fast, as opposed to brown rice or brown bread. It has anything that's whole grain or whole wheat will have more of a barrier, so it takes a little longer for the GI to absorb that. Okay, It's not so true for brown sugar, because brown sugar spikes your glucose level just as much. But the primary goal of a diabetic individual, aside from physical activity and losing weight, because you want your body to start burning that and exercising the metabolism of glucose, you also want to make sure that when they eat something, it doesn't spike their glycemic index. Okay, so when you eat, your blood sugar should, for the next 2 or 3 hours, have more of a nice little curved pattern, as opposed to a pointy, spiky pattern. Eat some white bread, and your blood glucose is going to go straight up, and within an hour, hour and a half, it's going to go straight down. It's going to be more linear. Eat something like a whole grain brown rice, and you're going to see that the sugar will still elevate somewhat, but it's going to take a little bit longer to get to its peak point. It's going to take a little bit longer to do. So it keeps you fuller a little longer. So if you're fuller a little longer, you have more time to maybe plan your meals, because we know that as soon as we get hungry, we want to grab whatever we can, because none of us like to be hungry. So it's something that really does have an effect. Increasing fiber in your diet, aside from all the other effects that it has on the colon, also makes you fuller faster. Okay, so eating fiber with your diet, soluble or insoluble fiber, will also increase your satiety. Okay, this will make you fuller and keep you fuller longer. So whole grains, whole wheat, and fiber is a good combination for a diabetic diet. Okay, you obviously want low sugar wherever you can, but that's the very basics of how you should advise your patients on how to eat. Okay, it's as simple as I could basically put it, without overwhelming any patient that doesn't really have any understanding of medicine or metabolism. So if there are any areas that I left out and you feel that I should go into more detail about something, or maybe I made a mistake on something, please go ahead and let me know and leave a post, and I will go ahead as soon as I can and change that error. Please feel free to leave comments, and go ahead and subscribe. All right. Hope this helped a lot of people out.